Welcome to the Deep Dive, where we cut through the noise to bring you the most compelling insights from the constantly evolving world of medicine. Today, we're plunging into a field that's all about movement, precision, and, well, relentless innovation. Orthopedic practice. It's such a dynamic space, isn't it? New techniques, groundbreaking technologies, and fresh understandings are emerging practically all the time, directly shaping how we look after our patients. Our mission today is to explore something absolutely fundamental to this progress, evidence-based medicine, or EBM, within orthopedics. And this isn't just about abstract concepts discussed in, academic papers. It's really about how robust, rigorously tested evidence has fundamentally reshaped our clinical decisions, and crucially, what this signals for the future of patient care. For you, our listener, a mid-senior professional navigating this complex landscape, staying truly abreast of these foundational principles, understanding the latest advancements, and appreciating the intricate regulatory environment isn't just good practice, it's absolutely essential. Essential for delivering the best possible patient outcomes. And guiding us through this essential deep dive, sharing his invaluable expertise, is someone whose contributions to orthopedic evidence and research, particularly from his extensive work at McMaster University, have been truly foundational. Welcome. So to kick us off, what does evidence-based medicine truly encompass in our orthopedic world? And maybe just as importantly, how did this really powerful concept first establish itself? Where did it come from?
Thank you. It's a real pleasure to be here. Yes, the term evidence-based medicine, EBM, it's ubiquitous now, isn't it? You hear it everywhere. But its origins are actually quite specific and perhaps surprisingly relatively recent. It was first coined around 1990, right there at McMaster University in Canada, by a core group of visionary minds. We're talking about figures like Gordon Guyatt, David Sackett, and Brian Haynes. They effectively, ignited this paradigm shift.
Okay, McMaster, 1990. So what's the core idea?
Well, at its heart, EBM is far more than just using evidence. It's defined as the critical integration of the best available research evidence with individual clinical circumstances. And perhaps most importantly, with the patient's unique values and preferences.
So it's that combination, not just the science.
Precisely. I often describe it as a harmonious, essential partnership between the scientific brain, that rigorous, objective pursuit of data, and the compassionate heart of medical practice. Truly understanding and respecting the individual patient in front of you. This ensures our decisions are not only scientifically sound, but deeply patient-centered.
That makes a lot of sense. The brain and the heart.
Exactly. And a few names really stand out in establishing this practically. Brian Haynes, for instance, made significant, highly practical contributions, really making research accessible to the busy clinician. He was instrumental in developing the PubMed filters that, many of us now use daily to easily identify randomized trials.
Those filters are lifesavers sometimes.
Think about it. He created almost algorithmic ways to navigate these vast amounts of information, enabling us to pinpoint the most reliable studies quickly. His pioneering efforts also led to the creation of pre-appraised evidence reviews, like the renowned ACP Journal Club, which for decades has distilled complex research into practical, digestible summaries. This was absolutely vital for knowledge translation, bridging that gap between discovery and application.
So making it usable, essentially.
Exactly. And concurrently, Gordon Guyatt's work focused heavily on educational knowledge translation, teaching clinicians how to critically appraise and apply this evidence. And his initial forays into designing and running large clinical trials. What's particularly noteworthy for our discussion today is that orthopedics was one of the very first surgical specialties to truly benefit from his emphasis on this rigorous research methodology.
Oh, interesting. So orthopedics was an early adopter.
In many ways, yes.
Yeah.
So EBM wasn't just a theoretical construct debated in ivory towers. It was a pivotal, practical paradigm shift. It explicitly moved medical decision-making away from an over-reliance on purely expert opinion or just unsystematic individual clinical observations towards a more data-driven, systematic, and ultimately more reliable approach. It truly, I think, democratized access to scientific rigor in clinical practice.
That's a crucial distinction, isn't it? It's not just finding the best study, but applying it to a unique patient in front of you, balancing the science with that human element. And what strikes me there, hearing about that shift away from purely expert opinion, is how deeply ingrained those older practices must have been.
Okay, let's unpack this further then. From that conceptual birth of EBM, how did it truly transform orthopedic practice itself? Because historically, orthopedics, like much of medicine, did rely heavily on individual experience and expert consensus, which, as you can imagine, often led to wildly disparate and sometimes quite perplexing approaches. To really illustrate this, let's maybe travel back in time for a moment. There's a truly compelling historical anecdote from the 1889 proceedings of the American Orthopedic Association. Imagine this. Surgeons presented a case of leg hypertrophy, where one leg was 3/4 of an inch longer in a 6-year-old child. What followed were just wildly divergent treatments, all based on isolated individual case observations.
Right, based purely on anecdote.
Exactly. One surgeon suggested a simple rubber bandage and then a high shoe on the shorter leg. Another diagnosed congenital occlusion of lymph channels and astonishingly recommended amputation,
Amputation, goodness.
which was carried out. A different specialist for a similar case treated it by stretching the sciatic nerve, having observed a lessening of calf size in a prior elephantiasis case where he'd removed part of the sciatic nerve.
This isn't just an interesting historical footnote. It highlights a clear, almost terrifying, absence of objective criteria to adjudicate treatment efficacy. It really was a bit like the Wild West of medicine.
A vivid picture.
So how exactly did the orthopedic community begin to shed these traditional, unsystematic approaches and progressively adopt a more scientific, data-driven methodology? How did we move away from that?
Well, that anecdote beautifully captures the challenge of that era, doesn't it? It vividly illustrates the critical need for a more structured approach. The orthopedic community, much like other medical fields, began to truly recognize the profound inadequacy and, frankly, potential dangers of anecdotal evidence. This wasn't a sudden epiphany, but a gradual collective demand for objective, systematic trials to truly validate treatment benefits. It became imperative to demonstrate why one treatment was superior, or at least as effective, as another, rather than simply relying on individual surgeons' experiences, no matter how skilled or well-intentioned they might be.
A fundamental shift in thinking.
Absolutely. And this shift in mindset saw the formal embedding of EBM into orthopedic publishing and discourse. A prime example and a truly significant step was the Journal of Bone and Joint Surgery, JBJS. In 2000, it established its dedicated evidence-based orthopedics section. This wasn't just some optional add-on, it was a clear and unequivocal signal.
A statement of intent.
Precisely. A signal of the journals, and indeed the broader orthopedic community's, commitment to this new paradigm. It served as a beacon, really, directing attention towards studies built on solid evidence. Then, in 2003, a truly pivotal step was taken, driven by visionary colleagues like Jim Wright and Mark Swankowski. JBJS mandated that all clinical articles submitted for publication must include a level of evidence rating.
The levels of evidence. That was crucial.
It really was. This classification system, which ranges from expert opinion universally acknowledged as the lowest level up to randomized controlled trials, RCTs, or systematic reviews of RCTs, the highest and most rigorous level, well, it provided a much-needed standardized framework. For clinicians, this meant they could rapidly and objectively assess the quality and reliability of published research.
So you could quickly gauge how much weight to give a study.
Exactly. Quickly discerning what weight to give to a study's findings before considering incorporating them into their practice. It greatly facilitated critical appraisal, moving away from subjective assessments to a more objective, transparent system. It was a game changer for navigating the growing volume of orthopedic literature.
And presumably, tools were developed alongside this.
Yes, beyond publishing, there was also a concerted effort to develop practical tools specifically designed to empower orthopedic surgeons. I'm referring to the user's guides to the orthopedic literature, championed by figures like Mohit Bhandari, Gordon Guyot, and Mark Swankowski. These guides were meticulously crafted not just to present evidence, but to equip orthopedic surgeons with the skills to critically evaluate and effectively apply published evidence in their daily practice.
Making it practical.
Absolutely. They often use highly relatable patient scenarios, for instance, assessing the best surgical therapy for a displaced distal radial fracture to make the process tangible, accessible, and immediately applicable. It was about turning surgeons into their own evidence evaluators, giving them the confidence to question, appraise, and then act based on the strongest possible data.
So not just reading the paper, but integrating it.
Precisely. Integrating that paper's findings into a complex clinical decision tree.
That's a brilliant bridge, really, from the theory of EBM to the practical tools that empower surgeons. And it brings us neatly to what many consider the very cornerstone of that robust evidence, the randomized controlled trial, or RCT. It's often referred to as the gold standard in modern medicine, and for good reason. It's truly fascinating to think about how this incredibly rigorous methodology actually evolved.
So, given the preeminence of RCTs today, could you perhaps guide us through their historical development? Maybe sharing some of those fascinating early examples that were instrumental in shaping the scientific foundation of clinical research when we were still figuring out how to approach clinical questions systematically.
Absolutely. The journey to the modern RCT is quite captivating and, perhaps surprisingly, spans millennia. It far predates modern medicine as we know it. It really underscores humanity's long-standing quest to understand cause and effect. Some scholars even consider what is perhaps the earliest example of a clinical trial to be found in the biblical book of Daniel, over 2,600 years ago.
Really? In the Bible?
Indeed. In this account, Daniel and three others requested a 10-day trial comparing a diet of beans, lentils, and water against the king's rich meats and wines. After 10 days, their countenances were reportedly fairer and healthier, demonstrating a rudimentary comparison between an experimental and a control group. While not a fully randomized trial, it certainly encapsulates the spirit of comparing interventions.
A very early controlled experiment.
In essence, yes. Moving into the 18th century, we see more structured, though still not fully randomized, experiments. Sir James Lynn's scurvy trial in 1747 is a classic. He meticulously divided 12 sailors suffering from scurvy into 6 groups of 2, placing each on a different diet to test various remedies.
The citrus fruit group.
Exactly. It was the group receiving oranges and lemons that showed the most significant and rapid improvement, effectively conducting a pioneering one-way analysis of variance in a clinical setting. Shortly after, in the 1720s, Cotton Mather's smallpox inoculation efforts in Boston provided a compelling example of a cohort trial. During epidemics, he compared the mortality rates of those who were inoculated about 2.1% versus the uninoculated population, where it was a much higher 17.1%, powerfully showcasing the benefit of intervention.
So systematic observation was developing.
It was, but the introduction of true randomization, however, was a later pivotal development that really propelled us towards the rigor we expect today. One of the first truly randomized trials in medicine was published by J. Burns Amberson in 1931 for tuberculosis. He divided 24 patients into 2 groups of 12, based on approximately matched pairs, and then, crucially, used a simple coin flip to assign them to either a sanochrysine treatment or a distilled water control.
A coin flip. That's simple, yet so profound methodologically.
Absolutely. This random assignment was a monumental advance, reducing bias and increasing confidence in the results. Fast forward 2 decades, and the British Medical Research Council's multi-center double-blinded streptomycin trial in 1948 became a robust and enduring model for future designs. Patients were randomized using sealed, numbered envelopes to ensure allocation concealment, their progress meticulously evaluated through monthly chest x-rays, read by 3 independent specialists who were critically blinded to the treatment arm.
Blinding another key step.
Essential. This meticulous design cemented the importance of blinding, multi-center collaboration, and robust objective assessment. It truly raised the bar for clinical research. Then the pinnacle of early large-scale RCTs is arguably the monumental Salk polio vaccine field trial in 1954, a colossal double-blinded study involving over 400,000 children.
Incredible scale.
Half vaccinated, half receiving a placebo of salt water. The sheer scale, the ethical complexity, and its rigorous methodology made it a gold standard for vaccine efficacy, demonstrating just how powerful RCTs could be in public health, fundamentally altering the trajectory of a global disease.
And this impact isn't just historical, is it? It still happens.
Oh, absolutely. The profound, almost disruptive impact reverberates even in recent memory. Consider the discontinuation of hormone replacement therapy, HRT, back in 2002. For decades, HRT had been widely recommended, based on what seemed like logical clinical observations and physiological assumptions for preventing osteoporosis, dementia, even heart disease. It was almost universal for postmenopausal women.
I remember that being standard practice.
Exactly.
Yeah.
However, the Women's Health Initiative, or WHI, trial, a massive, rigorous RCT, definitively showed increased risks of heart disease, breast cancer, and stroke, completely contradicting years of widespread clinical practice and deeply entrenched medical dogma.
A seismic shift based purely on trial evidence.
Absolutely seismic. A striking example of how rigorous, evidence-based findings, even when challenging powerful commercial and professional momentum, can completely overturn established medical wisdom and reshape patient care overnight. It really underscores why we need these trials.
That's a truly powerful illustration of how evidence can reshape practice, even against deeply held beliefs. It's almost a sobering reminder of why we can't just rely on intuition or observation alone.
Yeah.
So, transitioning to the contemporary landscape of orthopedic trials, particularly for high-risk medical devices, it's clear that certain trial designs have become incredibly prevalent. I've certainly observed a significant use of two-arm non-inferiority trial designs in pivotal orthopedic studies. For our listeners, could you unpack that a bit? What is the fundamental purpose of these non-inferiority designs, and why do their intricate design and often nuanced interpretation frequently spark such crucial debates within the orthopedic community? It feels like there's a bit of a tightrope walk involved, doesn't it?
You've certainly hit on a very pertinent and often contentious area. Non-inferiority trials are indeed a cornerstone of modern orthopedic device research, and it's absolutely vital to understand their specific purpose and inherent challenges. To clarify, we typically differentiate between two main types of trials when assessing new treatments: superiority trials and non-inferiority trials.
Right. Superiority aims to prove something is better.
Exactly. Unequivocally better than an existing one. Conversely, non-inferiority trials are designed to demonstrate that a new treatment is no worse than or acceptably close to an established standard of care. This distinction is absolutely critical in our field.
No worse than. That's the key phrase.
Precisely. And your observation about their prevalence is spot on. A comprehensive study examining FDA orthopedic and rehabilitation devices panel meetings from 2002 to 2016 revealed something quite striking. Staggering 87% of pivotal trials presented were RCTs, fair enough, but a substantial 65% of those were specifically non-inferiority designs.
Wow, that's a huge proportion. Why so many?
Well, the rationale behind this prevalence is quite clear and pragmatic, actually. Non-inferiority trials are essential when a new device or technique offers other significant advantages. Advantages that aren't necessarily about outright superiority in efficacy, but rather about overall value or patient experience.
Like cost or invasiveness.
Exactly. For example, a new orthopedic implant might be less expensive to manufacture, less invasive for the patient, simplify the surgical procedure, or offer improved convenience during recovery. These are highly compelling advantages that significantly impact healthcare systems and patient lives, provided, of course, the new treatment doesn't compromise efficacy or safety compared to an existing, often more expensive or complex, standard treatment. So the goal is to show it's good enough, clinically acceptable, while offering these other tangible benefits.
Okay, that makes sense commercially and practically, but you mentioned debates and challenges.
Yes, and this design isn't without its significant challenges. It frequently sparks crucial debates for very good reason. The most common and critical discussions revolve around three main areas, and this is where that tightrope walk you mentioned becomes particularly apparent. Firstly, there's the precise choice of the non-inferiority margin.
The margin, how much worse is acceptable?
Exactly. This is a predefined, statistically determined acceptable difference in outcome that we, as clinicians and researchers, are willing to tolerate between the new treatment and the standard one. If this margin is set too wide, a new, potentially less effective treatment might be mistakenly deemed non-inferior, potentially putting patients at risk or diluting the overall quality of care. It's a delicate and often subjective balance that can be heavily influenced by clinical judgment, patient values, and yes, even commercial pressures. Getting this margin wrong can have serious consequences.
A critical judgment call. What's the second issue?
Secondly, there's the critical issue of ensuring the active control arm is truly effective in the context of the trial. If the established standard treatment used as the control of the trial isn't performing as well as it typically would in real-world practice for whatever reason, then a new treatment might appear non-inferior even if it's genuinely less effective. This can lead to what's known as biocreep.
Biocreep. That's a chilling phrase.
It is, rather. A concerning phenomenon where less effective treatments gradually enter the market because they're compared against an underperforming control or against a predicate device that was itself only shown to be non-inferior to an even earlier, potentially suboptimal standard. It's a slow erosion of clinical standards that can be very hard to detect until it's potentially too late for patients.
A gradual slide downwards. And the third point.
And thirdly, there's the nuanced and extremely careful interpretation of results to avoid misleading conclusions. Because these trials aren't designed to prove superiority, drawing definitive conclusions about one treatment being better than another, based solely on non-inferiority findings, can be erroneous and must be done with extreme caution. Often a non-inferiority result is then spun in marketing materials to imply equivalency or even superiority, when the trial simply proved it wasn't worse by that predefined margin.
So careful wording and interpretation are key.
Absolutely. These debates are fundamental to maintaining the integrity of evidence generation, protecting patient safety, and ensuring that innovation genuinely improves care, rather than simply introducing alternatives without clear benefit. It requires constant vigilance from all of us.
That concept of biocreep really sticks with you, the idea that standards could slowly erode without us realizing it is a powerful argument for this vigilance. It's clear that while RCTs provide a robust foundation and non-inferiority designs play a critical role, the journey from a research finding to widespread clinical adoption is far from straightforward. Even with high-quality evidence, entrenched practices, personal preferences, and just the sheer inertia of existing systems can make shifts quite slow. So when high-quality evidence does emerge, what does that journey actually look like in practice? How readily do orthopedic surgeons really adapt their established practices and surgical approaches in response to new, compelling data? It's one thing to read a paper, another entirely to change how you operate, isn't it?
That's a profoundly important question, and it delves into the complex interplay between evidence, professional behavior, and clinical decision-making. It's not simply about presenting the evidence, it's about how that evidence is received and critically integrated into practice. To get a direct quantitative insight into this, we can actually look at a significant piece of research, the Can Orthopaedic Trials Change Practice survey. It canvassed 796 orthopedic surgeons.
Oh, brilliant. Real-world data on this.
Exactly. It provides fascinating, nuanced data on their willingness to adapt. The survey began by establishing a baseline. It revealed that 61% of the surveyed surgeons currently preferred hemiarthroplasty, or HA, for managing displaced femoral neck fractures. That was their established practice.
Okay, so HA was the default for many.
For the majority in that sample, yes. However, the truly compelling finding emerged when they were presented with a hypothetical scenario. If a rigorous trial definitively showed substantial improvement in patient function and quality of life with total hip arthroplasty, THA, without increasing the risk of revision surgery, would that evidence matter? A striking 72% stated they would consider such a finding important.
So there's an openness to the evidence itself.
A strong underlying openness, yes. Even if their current practice might lean elsewhere. Surgeons are not resistant to knowledge, quite the opposite, I'd say. But the real acid test was whether this perceived importance would translate into actual practice change. And here's where it gets particularly insightful. If such a trial were to confirm the superiority of THA in terms of patient-important outcomes, a notable 62% of those surgeons who initially preferred HA indicated they would change their practice.
62%, that's significant.
It is. Breaking this down further, 13% stated they would definitely change, 26% very likely, and 24% somewhat likely. This demonstrates a significant, albeit sometimes cautious, willingness to shift established methods when faced with compelling patient-relevant data. It's not a universal overnight shift, perhaps, but it's a powerful indicator of impact.
Was there anything that predicted who was more likely to change?
Yes, absolutely. A key differentiation observed in the survey further illuminates this dynamic. Surgeons who are actively members of research-oriented organizations like the International Hip Fracture Research Collaborative, or IHFRC, they were significantly more inclined to change their practice, a very high 92%.
92%, wow.
In stark contrast, members of broader professional associations like sift showed a willingness of only 48%.
That's a huge difference. What does that tell us?
Well, it clearly illustrates that an active engagement with research, and perhaps a specific interest in trials and evidence generation, directly correlates with a greater propensity to adopt new evidence. It highlights the profound importance of fostering a research-conscious culture and ensuring easy access to and understanding of new findings. It's almost like being part of the process makes you more receptive to its outcomes.
That makes intuitive sense, being closer to the source.
Precisely. And we see parallels in other medical fields too. For instance, cardiologists have been shown to be more likely to increase their prescription of drugs proven effective in recent trials if they had personally participated in those trials. This suggests that direct involvement, either through active participation or deep engagement with research networks, can dramatically reduce that gap between evidence generation and its adoption in clinical practice. It reduces the perceived distance between the abstract paper and the real-world application.
Okay, so the evidence can change practice, but engagement is key.
To summarize, yes. Large, high-quality clinical trials possess substantial power to alter clinical practice, provided the evidence is truly compelling, rigorously presented, and crucially speaks to patient-important outcomes. However, for that change to happen widely and efficiently, effective dissemination and active ongoing engagement from the surgical community remain paramount. It's not enough to simply publish the findings. They need to be absorbed, understood, debated, and championed by practitioners, often within supportive professional communities. It's a multifaceted challenge, but one with clear pathways to success.
That's incredibly reassuring to hear, knowing that orthopedic surgeons are, by and large, open to adapting their practice based on robust evidence. In fact, I recall a recent sentiment survey finding that 86% of Canadian Orthopedic Association members explicitly agreed that high-quality journals and rigorous RCTs are key influencers of their clinical decisions. That's a powerful statement about our collective commitment to progress. With that in mind, let's bring this right up to the present day. Could you delve into some of the most practice-changing orthopedic clinical trials published in just the last year, 2023? Which studies genuinely moved the needle and perhaps challenged existing paradigms in our field, giving us concrete, actionable insights that our listeners can think about?
Absolutely. It's an incredibly exciting time to reflect on recent advancements, and 2023 certainly delivered some truly impactful studies that are already reshaping how we approach orthopedic care. These aren't just academic curiosities. They have direct, tangible implications for our daily practice. Firstly, let's discuss the OPAL trial. This focused on opioids for acute low back and neck pain, a really significant piece of work. This was a groundbreaking, triple-blinded, placebo-controlled randomized trial. It involved 347 participants with moderate to severe acute low back or neck pain lasting 12 weeks or less. They were randomized to receive either guideline-recommended care plus an opioid specifically, up to 20 milligrams of oral oxycodone naloxone per day, or guideline-recommended care plus an identical placebo.
Okay, opioid versus placebo for acute pain. What did they find?
The findings were stark and, frankly, unequivocal. At 6 weeks, opioids offered no superior pain relief or improved physical function, quality of life, recovery time, or work absenteeism compared to the placebo. None. Furthermore, at 1 year, patients in the opioid group actually experienced slightly worse pain and reported a higher risk of opioid misuse.
Worse pain and higher misuse. That's striking.
It is, and adverse events like nausea, constipation, and dizziness were also significantly more common with opioids, as you might expect. The impact here is profound for you, our listener, in clinical practice. This study directly challenges the long-held but often weakly evidenced belief that opioids have a significant place in treating acute presentations of low back and neck pain. It provides compelling evidence to discourage opioids without qualification for these conditions, even when some existing clinical guidelines might still allow for their use in selected circumstances.
So, a clear message. Avoid opioids for acute back-neck pain.
That's the strong implication. It's a huge step towards better pain management and appropriate prescribing. It addresses a critical scarcity of high-quality evidence for acute pain and directly contrasts with earlier, often lower-quality research on chronic pain. The key takeaway for our listeners is that we can now confidently reduce opioid prescriptions for acute back and neck pain, freeing patients from unnecessary risks and potentially poor long-term outcomes.
That's incredibly important. What's next on your list?
Next, let's look at the buccal trial. This examined ultrasonography for pediatric distal forearm fractures. This was a multi-center, open-label, non-inferiority trial involving 270 children diagnosed with suspected distal forearm fractures. It compared point-of-care ultrasonography to conventional radiography for initial diagnosis.
Ultrasound versus X-ray for kids' wrist fractures. Non-inferiority again.
Yes, and the study found ultrasonography was non-inferior to radiography for assessing physical function at 4 weeks post-diagnosis. That was the primary outcome. But crucially, children diagnosed using ultrasonography experienced earlier discharge from the emergency department, missed fewer days of school, and both children and parents expressed greater satisfaction with their treatment, likely due to the quicker, less invasive diagnostic pathway.
Faster diagnosis, happier kids and parents, less radiation. Sounds like a win.
Exactly. The impact is clear and immediately applicable. These results strongly support point-of-care ultrasonography as a safe, efficient, and accurate initial diagnostic tool for these common pediatric injuries. This offers significant advantages: reducing children's exposure to ionizing radiation, potentially lowering costs for healthcare systems, and significantly enhancing the overall patient and parent experience. It really challenges the long-established gold standard of two-plane X-rays in this context.
A tangible shift towards a more child-friendly and efficient pathway for those in pediatric orthopedics? Brilliant. What else stood out in 2023?
Then we have the INSIGHT trial. This compared intramedullary nail versus sliding hip screw for trochanteric fractures, A really big, important study. This was a truly large-scale, international, multi-center RCT conducted across 25 sites in 12 countries. It compared surgical fixation using an intramedullary nail, specifically the gamma-3 striker, versus a sliding hip screw in 850 patients with trochanteric fractures.
Nail versus screw for hip fractures, a classic comparison. What did this large trial show?
Well, it found remarkably comparable outcomes in health-related quality of life, mobility, hip function, healing rates, and safety at 1 year post-operation between the two groups. Very similar results.
Comparable outcomes. But what about cost? Screws are generally cheaper, right?
Considerably cheaper. And that's where the profound impact lies for orthopedic surgeons. The INSIGHT trial provides robust evidence that the sliding hip screw represents an acceptable lower-cost alternative, offering equivalent clinical outcomes to intramedullary nailing in this large population. This finding directly challenges the increasing global trend towards intramedullary nailing, a trend that may have been driven more by industry marketing, surgeon preferences, or maybe reimbursement structures rather than clear clinical superiority.
So it urges a reevaluation of our default choices, potentially saving costs without compromising outcomes.
Precisely. It underscores the ongoing need for rigorous studies to identify optimal fixation devices and perhaps specific patient populations best suited to different approaches.
Very important findings. Let's hear about the fourth one.
The fourth trial I'd highlight is the White 8 trial. This focused on antibiotic-loaded cement in hemiarthroplasty for hip fracture. Another hip fracture study, but looking at infection prevention. This was a multi-center, randomized controlled superiority trial that enrolled nearly 5,000 older patients undergoing hemiarthroplasty for hip fracture. Patients were randomized to receive either single antibiotic-loaded cement or high-dose dual antibiotic-loaded cement.
Single versus dual antibiotic cement. Does more antibiotic mean fewer infections?
That was the hypothesis. But the primary outcome, which was deep surgical site infection at 90 days, revealed no significant difference between the two groups. Secondary outcomes, including mortality, quality of life, mobility, and other complication rates, were also strikingly similar.
No difference at all, despite using double the antibiotics.
No significant difference was found in this large trial. The impact here is critical, particularly for antibiotic stewardship globally. This large-scale trial provides powerful evidence directly contradicting earlier, often quasi-randomized studies that had suggested a benefit for dual antibiotic cement. It unequivocally demonstrates no additional clinical benefit of high-dose dual antibiotic cement over single antibiotic cement for these patients.
Which has huge implications for antibiotic resistance.
Absolutely. It helps mitigate concerns regarding increased risks of antibiotic resistance and potential renal toxicity from widespread, unproven use. For orthopedic surgeons, this means we can confidently avoid the unnecessary use of dual antibiotic cement in this setting, contributing to crucial efforts against antimicrobial resistance without compromising patient safety.
Powerful stuff. And the fifth trial.
Finally, the PREVENT Clot trial. This compared aspirin versus low molecular weight heparin for thromboprophylaxis after major fractures. This was another large, multi-center, randomized, non-inferiority trial conducted across 21 trauma centers in the U.S. and Canada. It involved over 12,000 patients with major pelvic, acetabular, or extremity fractures requiring surgery. It compared aspirin, 81 milligrams twice daily, to low molecular weight heparin, specifically 30 milligram enoxaparin twice daily, for thromboprophylaxis during hospitalization.
Aspirin versus LMWH for VTE prevention after fracture surgery. A major question. What did they find?
Aspirin was found to be non-inferior to low molecular weight heparin for the primary outcome, which was death by any cause at 90 days.
Non-inferior for mortality. What about clots?
That's the nuance. While most secondary outcomes were similar, including pulmonary embolism and bleeding complications, the rate of deep vein thrombosis, both overall DVT and distal DVT specifically, was statistically higher in the aspirin group.
So slightly more DVTs with aspirin, but no difference in death or PE.
Correct. So the impact for trauma and orthopedic specialists is substantial, but requires careful thought. This trial significantly contributes to the evolving evidence base, demonstrating comparable overall efficacy, particularly regarding mortality and PE, and safety outcomes for aspirin and low molecular weight heparin in this high-risk patient population. Given aspirin's substantially lower cost and the convenience of oral administration, these results are poised to influence future guideline recommendations, which currently often favor low molecular weight heparin. It provides a potentially safe, effective, and much more accessible alternative for many patients.
But we need to be mindful of that slightly higher DVT rate, perhaps.
Exactly. It adds crucial data to the ongoing discussion about the optimal thromboprophylaxis strategy, suggesting aspirin is a very reasonable option for many, but the choice might still depend on individual patient risk factors. It could dramatically change our post-operative prophylaxis protocols for a large number of patients.
Those are 5 incredibly insightful studies from just 1 year, truly highlighting the dynamic nature of orthopedic practice and the tangible difference rigorous trials can make. They offer real-world, actionable insights for our listeners. But while we're generating this high-quality evidence and seeing it shift practice, how does it actually make its way into the devices and techniques that you, our listener, use every day? Because that brings us to the crucial ecosystem of innovation and the intricate regulatory tightrope walked by orthopedic device manufacturers. It's a complex, often financially driven landscape. Could you clarify the 2 primary regulatory pathways for medical device approval, particularly within the United States, and explain how each path profoundly impacts both innovation and ultimately patient safety? It feels like these pathways have very different implications.
Of course. Understanding these pathways is fundamental to grasping the context of device development in orthopedics. In the United States, the Food and Drug Administration, or FDA, primarily uses 2 distinct pathways for medical device approval, and they differ significantly in their rigor, cost, and implications. The first is the PMA, or pre-market approval process. This is the most stringent and scientifically demanding pathway. It is specifically mandated for Class 3 devices, those deemed high risk, often life-sustaining or carrying significant potential risk of illness or injury. Think complex joint replacements, spinal implants.
The highest risk category, so requires the most evidence.
Absolutely. For PMA approval, manufacturers must provide robust clinical evidence that unequivocally demonstrates both safety and effectiveness. This typically demands well-designed randomized clinical trials or prospective data compared against rigorously defined historical controls. This is where that gold standard evidence is truly expected.
It sounds expensive and time-consuming.
It is. As you can imagine, it's an incredibly resource-intensive process. Financially, it's significantly more costly. The average concept-to-market cost is roughly $94 million, and about $75 million of that is directly attributable to FDA-related clinical trials and regulatory activities. The timeline is also considerably longer, averaging 27 months just from the initial submission to final approval.
Nearly 2.5 years just for the review, but presumably safer devices.
That's the clear benefit. The undeniable benefit for patient safety is that PMA-approved devices have a substantially lower risk of recall. They are 11.5 times less likely to be recalled compared to devices approved to the other main pathway. This stringency directly correlates with enhanced patient safety and confidence in the device.
Okay, so PMA is tough, but thorough. What's the alternative?
The second pathway is the 510(k) or pre-market notification process. This is an expedited pathway. It's primarily used for Class 1 and 2 devices, which are considered low to moderate risk. However, and this is where it becomes particularly relevant and perhaps concerning, for orthopedics, it's also surprisingly used for a significant number of Class 3 high-risk devices.
High-risk devices through an expedited pathway. How does that work?
It works through the concept of substantial equivalence. The 510(k) pathway allows devices to bypass comprehensive clinical trials if they can demonstrate substantial equivalence to an existing, legally marketed device, what we call the predicate device.
So if it's similar enough to something already on the market, it gets a faster track.
Essentially, yes. This route is much faster, averaging just 4.5 months for submission to approval, and significantly cheaper average concept-to-market cost of around $31 million, including $24 million for FDA-related activities. It's clearly a much more attractive commercial route for manufacturers.
Faster and cheaper.
Yeah.
But what's the catch?
The catch is the trade-off, especially in terms of patient safety. 510(k) approved devices carry an 11.5 times higher risk of recall compared to PMA devices. And alarmingly, up to a quarter of high-risk devices enter the market via this less rigorous route.
A quarter of high-risk devices. That seems problematic. And this substantial equivalence, how robust is that comparison?
Well, that's a critical question. A fundamental flaw with this concept is that it can become compounded.
Compounded, what do you mean?
It means a new device might be deemed equivalent to a predicate device that itself was cleared based on equivalence to an even older device. This chain of equivalence can potentially trace back through multiple predicates to products that were grandfathered into the market without any rigorous safety or effectiveness assessment since the regulatory framework's inception back in 1976.
Good grief. So if I'm visualizing this correctly, it's almost like building a modern skyscraper on a foundation that's itself built on the blueprints of a much older, smaller building, and no one has truly checked the original plans for decades.
That's actually a rather apt analogy. This chain of equivalence can severely dilute the initial safety assurances and poses a significant ongoing concern for patient safety, especially when we're talking about devices that are implanted long-term in the human body.
That analogy of building on potentially unchecked old blueprints really drives home the potential risks. That's a stark difference in both cost and, critically, the risk profile for patients. It brings me directly to the commercial realities of the orthopedic device market. You mentioned the lower costs of 510K. Investors, quite understandably, typically operate with a clear expectation of recouping their investment within a benchmark of approximately 7 years. That's a key figure for them. So, how do these disparate approval processes, particularly the resource intensive PMA pathway, influence the economic viability of orthopedic device innovation, especially for, say, less common conditions or smaller patient populations that might not promise massive commercial returns?
This is precisely where the regulatory framework directly intersects with the economic drivers of innovation. And the implications are quite profound, extending far beyond just the manufacturers themselves to directly impact patients and what treatments become available. A rigorous financial feasibility study that meticulously analyzed 13 orthopedic medical device systems sheds critical light on this dynamic.
Okay, what did that study show?
For devices cleared through the 510K process, the picture for investors is generally quite favorable and predictable. Most devices were projected to recoup their initial investment well within that critical 7-year benchmark. The average time was just 2.4 years. Only one device in the study, a radial plate system, slightly exceeded this at 7.715 years. This swift and relatively low-cost return on investment clearly incentivizes manufacturers to use this expedited pathway whenever commercially viable, accelerating market entry.
Makes sense. Fast return, lower risk for investors. What about PMA?
In stark contrast, for devices subjected to the PMA route, the average recoupment time stretched significantly to 8.5 years, well beyond that 7-year mark. More tellingly, a significant 6 out of the 13 orthopedic device systems analyzed, including devices like the tibial plate system, shoulder replacement, reverse shoulder replacement, radial plate system, anterior cervical spacers, and anterior surgical plate system, would require longer than that crucial 7-year investor benchmark to recoup costs.
So nearly half the devices studied wouldn't meet typical investor
Yeah,
expectations via PMA.
exactly. And to put the dramatic difference into perspective, that radial plate system, for instance, would take 8.4 times longer to recoup its investment if subjected to PMA approval compared to something like a high-volume knee implant going through the same process.
8 times longer. That's a huge financial hurdle.
Immense. The profound implications of this disparity are multifaceted and touch upon equity of access to innovation. Broad mandatory PMA requirements, while undoubtedly ensuring a higher standard of safety and efficacy, would disproportionately penalize innovation for low-volume, low-margin devices catering to less prevalent orthopedic conditions.
So investment would just flow to the big markets.
What happens then is entirely predictable, isn't it? Investment capital would inevitably concentrate on high-volume markets, such as hip and knee implants, and high-margin segments, like complex spine devices, where the financial returns are quicker, larger, and more assured. Companies, quite rationally from a business perspective, will chase the most profitable avenues.
But this isn't just an economic issue for companies, is it?
No, absolutely not. It's a critical issue of patient equity and access. Patients with rarer orthopedic conditions, or those requiring more specialized niche devices, could genuinely suffer from a severe lack of novel, tailored device development. The financial incentive for manufacturers to invest hundreds of millions of many years in the rigorous, expensive, and lengthy PMA process simply wouldn't be there for smaller markets. It creates a complex ethical and commercial balancing act, ensuring stringent safety standards versus fostering an environment where innovation can still thrive for all patient needs, not just those in the largest commercial markets. It truly shapes the landscape of what gets developed and what simply doesn't.
That's a truly sobering thought that market pressures could inadvertently leave certain patient groups underserved despite the best intentions for safety. It highlights a significant tension, doesn't it? How do we balance stringent safety requirements with the imperative for continued innovation and commercial viability in orthopedics, especially when the current frameworks seem to have limitations, particularly for truly novel or lower volume devices? So, considering all these identified gaps and challenges, what are the most critical changes and new frameworks being proposed in regulatory guidance for both clinical investigations and broader device approval to better serve patients and foster responsible orthopedic innovation, ensuring maybe that no one gets left behind?
That's precisely the challenge we must address to move forward responsibly, ensuring both patient safety and the continuous progress of orthopedics. It requires a multi-pronged approach. Insights from comprehensive analyses, such as the Core MD Systematic Review, which meticulously examined recommendations for pivotal clinical investigations of high-risk medical devices from international regulators and ISO standards, point to several urgent and crucial needs.
Okay, what are the key recommendations coming out of that kind of work?
Well, a key finding is that there is an urgent demand for more systematic and explicit guidance that clearly differentiates between the requirements for established high-risk medical devices versus truly novel high-risk devices.
Ah, treating new concepts differently from iterative updates.
Yes, exactly. The current general standards, such as ISO 1415v5 on good clinical practice, while undoubtedly valuable as a broad framework, often provide overly broad recommendations. They aren't specifically tailored to the unique complexities and risks of high-risk medical device studies. They essentially treat all devices with a broad brush, which simply isn't always appropriate for the specific risks, benefits, and innovation trajectory of, say, a new joint implant compared to a novel diagnostic tool.
So we need more specific guidance.
Yes, there's a strong and growing call for more device-specific ISO standards or the development of common specifications. These must ensure that regulatory requirements are deeply rooted in the current state of the art, meaning they should be informed by systematic literature reviews, real-world data, and importantly, consensus statements from representative professional bodies in orthopedics. This ensures the evidence required is relevant, proportionate, and truly addresses the specific risks and benefits, rather than being a generic checklist.
Making the requirements fit the device better.
Precisely. It allows for more targeted and efficient evidence generation. We also need to critically address the challenge of objective performance criteria, or OPCs. While these are recommended for established devices essentially, benchmarks against which new devices can be compared, there's currently insufficient clear guidance on how these criteria should be robustly derived.
How do we set the right benchmarks?
It's crucial that OPCs accurately reflect changes in the standard of care over time, consider the nuances of different patient populations, and incorporate appropriate statistical considerations. They need to be truly meaningful and not just historical artifacts. Without this, the benchmarks against which new devices are measured can become outdated or inappropriate, potentially leading to those misleading non-inferiority conclusions, feeding that biocreep we discussed earlier.
Right, keeping the goalposts relevant. Are there positive signs, though? Is regulatory thinking evolving?
Oh yes, on a more positive note, we are seeing some incredibly promising developments in regulatory thinking, indicating a move towards more adaptive and patient-centered approaches. Newer FDA guidance documents, for instance, are increasingly comprehensive and forward-looking. They integrate advanced study designs like Bayesian and adaptive trials.
Adaptive trials. How do they help?
Well, they hold the promise of reducing necessary sample sizes while effectively addressing uncertainties and allowing trial design to adapt as data emerges. This could significantly cut down on the time and cost of trials without sacrificing rigor. Critically, these new guidelines also place a crucial emphasis on patient engagement in the planning of clinical investigation designs, ensuring the outcomes measured truly matter to patients, moving beyond just technical success.
Bringing the patient voice into trial design.
Essential. Furthermore, these guidelines actively address the persistent issue of underrepresentation of specific population subgroups based on gender, age, or ethnicity, for example, in trials, striving for more inclusive and generalizable evidence. Vital for equitable healthcare.
That sounds like real progress. What about specific areas like joint replacement?
Well, specifically within total joint arthroplasty, or TJA, despite the recognized gold standard of RCTs, there's a noted scarcity, particularly concerning prosthetic design and implantation. For example, a review in 2021 found only about 13% of knee arthroplasty RCTs focused on prosthetics, and none were conducted in the U.S. This highlights a significant gap where more rigorous evidence is desperately needed to compare different implant designs and surgical techniques.
So even in high-volume areas, we need more comparative evidence on the actual implants.
We do. Ultimately, the way forward involves a flexible yet rigorously evidence-driven approach. While awaiting more prospective RCTs, which remain the ideal, Other high-quality study designs, such as large-scale database analyses and national registry studies, are increasingly recognized as appropriate and necessary for the continuous evaluation and approval of new prostheses and techniques in the rapidly evolving TJA field.
Using real-world data more effectively.
Yeah, exactly. These provide invaluable real-world data on long-term performance. An effective regulatory framework in the future must meticulously balance stringent safety with the imperative for innovation, perhaps through integrated pre-market and robust post-market surveillance systems, and a greater collaborative use of comprehensive national and international registries to continuously monitor device performance in the real world. This holistic, data-driven approach is vital for both safeguarding patients and fostering responsible progress.
What an illuminating deep dive this has been. We've really covered a lot of ground. From the foundational history of evidence-based medicine, exploring the critical role and evolution of randomized controlled trials, including those tricky non-inferiority designs. We've also delved into the sometimes surprising factors that influence a surgeon's adoption of new evidence, seen the real-world impact of transformative trials from just last year, 2023, and really considered that complex financial and regulatory tightrope walked by orthopedic device innovation. It truly is a dynamic and multifaceted landscape. For you, our listener, a mid-senior professional in this field, staying critically engaged with evolving evidence isn't just, ticking a box for professional development. It's a profound, ongoing commitment to excellence in patient care. It means constantly asking the right questions, appraising the data critically, and adapting your practice for the best possible outcomes for the people you treat. If you found this deep dive particularly valuable, please do take just a moment to rate and share the show with your colleagues. Your support really helps us continue to bring these essential discussions to a wider audience. And as the orthopedic landscape continues its dynamic evolution, let's perhaps leave with this provocative thought for you to mull over. How will each of us actively champion evidence-driven decision-making in our daily practice? And what collective steps must we as a community take to ensure that innovation in orthopedic devices truly meets the needs of all patients, transcending the sometimes overwhelming commercial pressures of the largest markets? Thank you so much for your truly invaluable insights and expert guidance throughout this illuminating conversation. It's been absolutely fascinating.
The pleasure was all mine. Thank you for having me.
And thank you all for joining us. We invite you to join us again for our next deep dive.